going to give you a little update about our world. And the title of my part of the talk is Medicare for All, Why Bother? You may think this is kind of an odd title, but I have to say, we're not unaware of the fact that there are other issues that are commanding your attention as well as ours. For instance, now we have a war in Europe to worry about. Even before that, we've had climate change, voting issues, and all kinds of other issues competing for our attention. But what I want to persuade you of today is that we need to keep our eyes on healthcare too, and I'm going to talk about why that is. So, I'm going to start with some take-home messages that I hope you learn by the end of this talk. I want to talk a little about some things that are getting worse. Outcomes, access, costs, health equity are all things to be concerned about. Some new policies are actually going in the wrong direction. And if we do nothing, healthcare will get worse. But I'm going to end on the positive note of things that you can do to make a difference. Now, please don't take these take-home messages home right now. I hope you'll stick around for me to make the case about these. So I'm going to start by talking about some healthcare outcomes. First, I want to talk a little bit about life expectancy in this country compared to other comparable countries. When we talk about comparable countries, I mean other wealthy countries. And there, you can see a few things on these two lines on this graph. And one is that if you look at us compared to an average of other countries, we've always been behind, or for a long time, we've been behind other countries in life expectancy, going back at least till 1980. But if you look at what we're doing over the course of time, what you can also see is the gap between us and other countries is getting wider. And in the last few years, even before the pandemic, if you look there, what you can see is that we plateaued for a little while and then we dipped. Our life expectancies actually became lower. Now, other wealthy countries didn't have those dips. Their life expectancies kept on going up. The last little piece is 2020 with the pandemic, and what you can see is that our life expectancy went way down, more than other countries. I'm going to talk a little bit about this. Okay, now we get to one of the two, what Dr. Bonfog refers to as the ugly slides. I apologize, I didn't make these slides. I borrowed them. But I think they make the point that if you look at how much life expectancy changed in various countries, what you can see is that if you look on the left side of the graph, those are all countries where life expectancy decreased in 2020 due to the pandemic. Over to the right, there are countries where life expectancy actually increased somewhat. But our decrease in life expectancy was second only to Russia, which I think is not a country we'll want to compare ourselves with in any kind of way. And the point that I'm making here is that the extent to which it decreased in the pandemic was not inevitable. It didn't have to be. We didn't have to have as many deaths and as much of a change as we did. And now, looking at the effect on health equity, what you can see in this slide is, a couple things: difference in Black, Latinx, and white life expectancy in over time. And what you can see is that if you look in 2019, again before the pandemic, white life expectancy was higher than Black, and in 2020 it went down 1 year. But Latinx and Black life expectancy went down 3 years during the pandemic. So in 2019, the gap between black and white life expectancy was 4 years, which that really wasn't, by any measure, that wasn't acceptable, and our goal was to narrow the gap. But since the pandemic, the gap in life expectancy has increased to 6 years. In other words, as we know and as we've heard in different ways, COVID has affected minority communities disproportionately. Here we have a slide that's about maternal mortality. If you all have been paying attention to the news, you probably know that maternal mortality is a very serious problem in this country. Maternal mortality is deaths in women that are related to pregnancy or childbirth. And this is before the pandemic. What you can see is, again, when you compare us to other like countries, our maternal mortality is at least twice of what other countries have. Really not acceptable. Now, since the pandemic, it actually got worse. That number, this is a number per 100,000. So that number, which was 17 per 100,000, has gone up overall to 24 per 100,000. But again, if you look at the black maternal mortality in the pandemic, it had started at 38 and went up to 55. And that is comparable to countries like El Salvador and Mongolia and Egypt. All poor countries. We shouldn't be in any kind of comparison with them. So that's a little bit about what our kind of health outcomes are in this country. And now moving ahead to costs of our healthcare system. So if any of you have ever been to one of these gatherings, which we haven't had since the pandemic, but this will be a familiar slide to you, and we update it. And this compares what we spend on healthcare to what other countries do. Now, most people know that our healthcare is more expensive than other countries. So this slide will tell you at least two really important things, which is the extent to which it's expensive, which is about per capita, per person, it's about twice as expensive as most other developed nations. But the other really important thing on this slide is the division between private and public spending. Most people think of the United States as having private-based healthcare. But if you look at the slide, what you'll see is that actually about 2/3 of our healthcare spending is actually public spending. And the amount of public money that's in our healthcare system is more than the total budget of every other country that you can see on this graph. Now, for their public spending, they cover every single one of those countries, covers everybody, which obviously we do not. But the point I want to make to you about this is, when people tell you we can't afford to cover everyone, the money is there. It's there, we're just not spending it well. So that's kind of a national look at expenditures. What about families and individuals? Okay, the impact of our costs are that over half of adults skipped or delayed care due to cost. Now, sometimes people see a number like this and they kind of say, well, people in this country get too much medical care anyway, which actually isn't true. But if you look at what they skipped, it's not necessarily elective things. Like 1 out of 6 people skip mental health care. 1 out of 8 people actually skip hospitalization. Almost 1 in 3 didn't take medications as they were directed. Now that means either they didn't fill prescriptions at all because they couldn't afford them, or I can tell you what my patients did when I was in practice. They stretched their medications, which means that maybe they took it every other day, medicine every other day, maybe they took it twice a day, medicine once a day, which, that really isn't the way that medicines work. Now, not surprisingly, because of what our culture is, Blacks and Hispanics, people who are uninsured, and people with chronic illness are more affected by medical bills, but actually even insured people are affected by medical bills. And in 2018, almost half of non-elderly adults were underinsured. And underinsured means that they had insurance, but either they still couldn't afford to get medical care, perhaps because they didn't have the money to pay their deductible, or they were sick and got medical care and then couldn't afford to pay their bills. A little more about cost to individuals. Again, looking at adults under 65, over a third had a medical problem or debt, and you can see what some of those are. Those are like being sent to a collection agency. And again, that's half of the uninsured people had problems with debt, but over a third of the insured people are having a problem with medical expenses. So in this country, people are always talking about more and much fewer people insured the insurance rate, but having health insurance doesn't necessarily protect you. So what's the point I want to make here? I want to make the point that if we do nothing, things aren't going to stay the same. They haven't been staying the same, and predictably, they're likely to get worse. So let me talk about a few healthcare changes that are going on, some good, some not so good. How many people have heard about the No Surprises Act? Okay, well, the No Surprises Act was passed a while ago, but it was implemented this year, and basically the premise of the No Surprises Act is that if you go for medical care thinking that you're in-network, but you inadvertently, you go someplace out of network, like the kind of thing that's been happening is people have had surgery in an in-network institution with an in-network surgeon, but the anesthesiology is out of network and they get a huge bill. So with the a bill that's a surprise bill, and there are a variety of other kinds of surprise bills. With the No Surprises Act, it takes care of surprise bills and basically requires the providers to charge an in-network. So surprise bills have been a big problem, and that sounds good. The problem is that there are a lot of loopholes in the bill. There are a lot of hospitals are covered, but a lot of things aren't covered, like hospices. Urgent care centers are not covered. So there will be people still getting surprise bills. And then we have prescription drug controls these were in the Build Back Better Act had a variety of things that were supposed to control prescription drugs. And they were They were somewhat good, they weren't adequate, but the bill didn't pass, so you haven't seen any prescription drug controls. The American Rescue Plan Act basically expanded Medicaid and Affordable Care Act plans, made them more affordable, and probably because of this, the number of uninsured people in this country didn't drop as much during the pandemic as might have been predicted. However, what I would note is those are not permanent changes, those are temporary changes, and they will pass. They will, if they're not renewed, they will end. So we have Medicaid Expansion has been a big improvement. 38 states have expanded Medicaid. I'm sorry to say that 12 have not, and we are one of those that has not taken advantage of this expansion. Though I can tell you that Brandon Lofton is working very hard to change that. And then there's the the question of Medicaid contraction, because the American Rescue Plan, as I said, during the public health emergency, the states cannot recertify people who are on Medicaid. They have to keep people on Medicaid roll. So what's going to happen? You've heard people talking about ending the public health emergency. When that ends, there will be people who have to recertify again, and many of them will lose their Medicaid coverage. Now, this is a good thing. There is much more, I've seen so much more about addressing racism in healthcare in many places where we haven't seen it before. So one is the American Medical Association, which has a chief health equity officer now, and which has a really, I think, very thorough and remarkable plan for addressing racism in healthcare. And we need to keep our eye on whether they see it through. The North Carolina Medical Society also has done work in this, and the U.S. Public Health Services Task Force, which gives all kinds of recommendations about prevention, is now acknowledging that they have never looked at racism and the effect of racism, and they're going to look at it in all their recommendations about prevention going forward. And an unqualifiedly bad thing is the privatization of Medicare, which Dr. Bonfock is going to speak to after I speak. So there really is a more comprehensive solution. I want to, and we have a bill in Congress. It's the Medicare for All bill, HR 1976, and I just want to remind you all what's in it. It's comprehensive, all necessary care will be covered. It's universal, all residents of the United States will be covered. There is no cost sharing, that is no deductibles, no co-insurance, and no payment at point of service at all. It's affordable for everybody, and if you don't want to take my word for it, the Congressional Budget Office has said that the country will save money on this. Less bureaucracy for those of us in the room who are patients, which is all of us, and less bureaucracy for providers. Fewer forms and aggravation. Free choice of doctors and hospitals, public accountability, which you don't have now. And it establishes an Office of Health Equity as well as an Office of Primary Care to really advance those important things. So I want to talk some about the things that would become non-issues under Medicare for All. And this is a little game I play with myself, which I encourage you to think about too, which is when I see issues about healthcare, I think, well, what would that issue be if we had Medicare for All? And a lot of things would be non-issues. For instance, surprise bills. We wouldn't have surprise billing because everybody would be under one system. Now, related to that, there's the issue of out-of-network care. Now, out-of-network care applies to some big things and some small things. So, a big thing is, if you are diagnosed with a cancer that you didn't have when you were picking your network or you're picking your doctors, which is, usually how it happens later. And someone tells you that your cancer would be best treated at MD Anderson or at Sloan Kettering or at Duke or Chapel Hill, you wouldn't find that the place that you want to go is out of your network. So that's kind of a big thing. A small thing is, if you're like me and you're in New York and you have this pain in your foot, which I knew was a stress factor because I've had one before. And I knew once my husband persuaded me that I had to seek care for it. The question that came out of my mind was like one question all at once. What is the nearest urgent care center that takes my insurance? And so I have traditional Medicare, so I knew I was going to be okay. I just found the nearest urgent care center. But if you have private insurance, or if you have Medicare Advantage, That might not be true. You know, you might not be able to go to the best and the most convenient place. We have racial inequities and gender and sexual preference inequities in health insurance coverage in this country. The coverage inequities would go away because everybody would be covered. And which is not to say that outcomes would immediately get better, but I can tell you we could make a big dent in those outcomes if people could all get health care. Now, a very topical thing now that you may have seen is all this discussion about what's coming up and whether COVID testing and treatment is going to continue to be covered, because it was covered, Congress covered it, and then the president wanted a bill to continue to cover it, and Congress hasn't passed that bill. So are we going to continue to have COVID? And might we have another surge? And might we have people again who can't get tested or vaccinated or get the treatment they need? And, you know, and there's a lot of discussion about this. Well, we wouldn't be having those discussions, and Congress wouldn't be having those bills because healthcare would be covered. And then we get to the very uniquely American double whammy of you get sick, you know, you're scared, you may be in pain, you're anxious from your illness, and then you go get that addressed. And then you've got the double whammy of getting bills and all the suffering and anxiety that goes with that as well. And we wouldn't be in that, like people in other countries, we wouldn't be in that position. So, I want to let you know what our hardworking board and committees and everybody and all of you who participated have been doing. We speak to and we contact our representatives and their staff, and I want to say that often we're very effective, and I want to thank Congresswoman Adams because she's a co-sponsor of HR 1976. And she has also signed the letter opposing ACO REACH, which you're going to hear about shortly. So I just want to let you know that's an example of how your actions can actually work. We give talks, and we would be glad to give them elsewhere. We've got very good, we can give them in front of screens, although I have to say it's much better to give a talk in person with you all. We've written letters and opinion pieces, we've got the videos that Joanne has told you about. We align with other organizations such as Physicians for National Health Program, our parent organization, the State Coalition for Medicare for All, the Poor People's Campaign, and also the Coalition for Truth and Reconciliation, which I'm trying to get on this slide, but it wouldn't let me. I don't know why. And here, ending now my part, here are the things that you can do. I encourage you to join PNHP, Physicians for National Health Program. For those of you who are not physicians, it costs only $50. Doctors, they think you make a little more money than that, and it costs a little more than that. Encourage you, if you haven't joined our organization, please do. And we can tell you how, and encourage your friends to join us as well as PNHP. Make sure your member of Congress knows that you support Medicare for all. Let your public officials and politicians know, those who are here and others, because this important issue is important to them too. Please do read our emails when you get them. And even open them up and click on the links and make some of the phone calls or send the postcards that we ask you to do. Many of the things that we ask you to do really take less than 5 minutes. And I would also encourage you to join the committee. Whatever skills you have, believe me, we can use them and we will use them. So I want to thank you all for being here and for working with us on this. And I will turn this over to Dr. George Baum.